Welcome back, and today we're going to talk about cervical spine full assessment. So we're assuming that you've gone through and done your history, which means you have a pretty good idea of your differential diagnosis list and key areas that you might want to focus on for your exam. What the purpose of this video is to take you through an idea of what a generic cervical spine exam might look like. So you've gone through your history. Don't think you can't ask questions when your history is done. As you're going through and doing your assessment, ask more questions if more information becomes available to you. The next thing you're going to do is look at inspection. So history, inspection. One key thing that I should cover before you get into inspection is you want to make sure that you have approval from the patient to proceed with a hands-on assessment or exam. I know it might sound silly, the person knows why they're there is to actually have this stuff assessed, but just to make sure you're maintaining appropriate boundaries with your patient, you're going to give an introductory statement, something like, I'm going to perform a hands-on assessment and take you through some range of motion and different tests, and I just want to make sure that you're okay with that, and if you have any pain or discomfort, to let me know at any time. Okay. So the key thing here that I'd start with is inspection. And inspection usually involves a postural assessment. So you can, if you don't have it in your office, you can just sit and look at the patient to look for head carriage forward and back. You can look for the shoulders, how are they rotated. You can stand in front of the patient. What I'd recommend you do is use a wall chart. So we'll have you go ahead and stand up. And the key thing here is that the grid pattern lets you see a little bit better what's going on. So Carly, I'll have you just stand just in the center of it, looking this direction. So a couple of things. The nice thing with the grid pattern is you can compare shoulder height. You can look whether the head is up and down midline, all that variation that you can see. Okay, we'll have you go ahead and turn to the side. Turning to the side will give you a simple variation to look for the anterior head carriage, posterior head carriage, all right, whether she's rotated to one side or another, and then we'll have you spin right to the back. All right, what can happen is you can be tricked a little bit for your inspection, especially when people with long hair. It hides the area that you want to look at. You want to definitely inspect and look at the skin and see if there's any redness or swelling or something, or maybe even the person has been rubbing their own neck quite a bit. That might be a clue for you for areas that you want to work into. All right, we'll get you back sitting down. So that'll be inspection. The next thing is palpation. Now for palpation, and this is where I think a lot of practitioners fall down, is you basically want to give an anatomy lesson. You've paid thousands of dollars to gain all this anatomy knowledge that you have. Why not put it to work and look at the back of somebody's neck? This includes bones, ligaments, muscles, nerves, vessels. Every part of the anatomy, you should be able to at least have some concept or visualization of an idea of what's below your hand. So if I was going to do palpation in an area for the neck, first thing I would do is, after observation is done, I would go ahead and just start just nice and light. You're just doing a nice light lift into the tissue, see how it moves. You definitely want your first contact with the patient to be a very gentle, light contact. Probably one of the worst things a practitioner can do is the patient says they have pain there, and you just go and push right into it with a lot of force. Okay, nice light contact. Just see how the tissue's moving. Lift it up. Come down into the traps. Okay. Maybe even potentially a little bit behind the patient. You know, it's going to vary depending on your own clinic setup. See how everything's moving, follow your way up. Maybe you're staying superficial, looking for lymph node tightness, any kind of gland issues, anything like that. Into the masseter, if there's a TMJ issue. All of this stuff is potential for palpation. Maybe you want to go in here and just check general motion from side to side on the front of the neck. All right, scalene muscles all the way through, clavicle, you're feeling spinous processes, all this stuff, okay? Give an anatomy lesson for what's below your hand. So inspection, palpation, the next thing we do is range of motion. So for range of motion, again, your introductory statement, if anything's painful or uncomfortable, please let me know right away, and don't do anything you feel will cause you further injury. Okay. So the first thing I'll have you do is go ahead and flex all the way down. And is that as far as you can go? Yes. Yep, all right, and then all the way back up, and extending back just a little bit. And any pain or discomfort with that? Nope. Nope. I'll have you lean to the side. And can you go ahead and lean to the opposite side? I'm looking for muscle firing patterns, any kind of catching, and then back to neutral. Now we're going to have you spin your head to look over one shoulder, and then I'll have you spin in the opposite direction, and then back to neutral. So that's active range of motion. For most patients, especially for a general screen, I probably wouldn't do passive range of motion, but realistically, you're doing this exam because they do have a neck issue that they want to have addressed, so passive range of motion is warranted, and it will give you more tactile information as far as potential muscle tightness. And remember, this is part of your assessment being therapeutic. This range of motion passively will also offer some benefit for that patient potentially, okay? So the first thing that I'll do is go ahead, again, this hand palpating over top of the back of the neck, this hand just on the hairline at the front, and I'm going to lean you to the side like this, and a little bit of overpressure. To the side like that, and a little bit of overpressure. Extending back with a little bit of a lift, and we're going to have you turn to the side this way, and then turn to the side that way. And then back to neutral, and I just want you to flex forward for me, and a little bit of overpressure, okay? That overpressure is what gives that little bit of stretch at the end. Now, was that truly passive range of motion? No, absolutely not. I mean, we'd have the patient lay down, and I do that as part of a later assessment, definitely. I'm trying to be efficient with my time and make sure to do things in the seated position while she's here. Resisted range of motion, probably not going to do it unless I'm really concerned about muscle weakness. Generally, where do I see that? It's going to be some type of whiplash injury, in which case what I'll do is I'm just going to try and push your head back like this, and don't let me do that. Hold, and relax. If she did have whiplash or some kind of cervical sprain strain, you'll see that they're either weak or when they try and hold, there's a lot of shaking and the person's not really that strong when they're holding that position. So history, inspection, palpation, motion. The next thing is going to be your neurovascular screen. Realistically, even the range of motion was already part of your neuro screen because muscles are controlled by nerves, and that's part of a neurologic exam, all right? We're going to add a little bit more to it. A couple of things that you could also check would include things like sensation if you want it. So our main dermatomes over the face are going to be the trigeminal nerve, and these are going to be V1, V2, V3. And the way to test this, I'm going to have you close your eyes, but before you do, what I'm going to do is lightly brush my fingers over top of the skin of your face, and I want you to tell me if it feels the same or different from one side to the other. Okay, so go ahead and close your eyes, and...
Same. Different?
Different. Got to check them. You got to keep the patient honest.
Same.
So that'll be V1, V2, V3. If you're concerned about more upper cervical neurologic issues, you can be onto the top of the head here. She doesn't really have to close her eyes because she can't, most people can't see the top of their head. Okay, but right here, this is going to be C2 up at the top. Sometimes it's C1 in anatomical variation, but this is mainly C2. You're coming down here, C3, C4, C5. What you would do is have the patient's hands out in front of them like this, and this will get you into C6. Down the middle finger is going to be C7, T1, and then just arms a little bit further apart, and then T2 on the inside of the arms right there. That would basically cover you through all the brachial plexus and the innervation that it supplies. Again, same or different from one side or another. If you have a high index of suspicion of neurologic compromise, you would also perform sharp dull as well. Other things you could do would include, for the neurologic portion, would be deep pendant reflexes, and our basic reflexes for the upper extremity are going to be C5 at the biceps, C6 brachioradialis, and then the arm can be up like this, C7 for triceps. All right, and again, those are approximate spinal levels. There are fibers from other levels there as well, but mainly that's the area that they're supplied by. Anything else for the neurologic?
No, just comparing the reflexes bilaterally.
Good, yeah, and that would be the key thing too, bilateral comparison. And I didn't verbalize that, absolutely, Carly, you're right. Bilateral comparison has to be there. For the vascular screen, there's a couple of things you can do. The first thing is, even just general contact like this down the arm, you can feel if the skin is warm. Even if you squeeze the skin like this for a second and let go, you can see the capillary beds get blanched and then refill. So you can see capillary beds potentially anywhere in the body. The other thing you can do is check even nail beds if the person doesn't have nail polish on. You can go ahead and squeeze nail beds and then look for that to refill. You should see refilling within 2 seconds, okay? And anything else for vascular? Of course, you can also check pulses distally, radial pulse, ulnar pulse if you want. If you're really in depth, you could do a brachial pulse. Back into the cervical spine itself, you can get a carotid pulse and even a superficial temporal pulse out of the side as well. So history, inspection, palpation, motion, neurovascular screen. The next thing is referred pain. This is just there to give you an idea of things that could refer pain to the neck that are actually not neck pathologies. And this can be anything from visceral, like even heart attacks in women can have odd presentations that present as pain up into the neck, difficulty swallowing potentially, upper shoulder blade, okay, even cervical thoracic issues can refer up into this area as well. Referred pain, and then the next thing is going to be special tests, and that's where you continue on for the rest of this, where you'll select special tests based on the conditions that you want to rule in or rule out. You do not perform every special test on every patient. I don't know if there's anything else you want to add for that, Carly, all the way through?
No, I think that's good.
Okay, so it's a good basic cervical spine introduction. Again, your own clinical practice, you'll have to decide what I'm going to use, what I'm not going to use, and away you go from there.